Dr. Criado is going to present on the management of intramural hematoma in this territory.
Thank you, Donald. Intramural hematoma of the thoracic aorta is, of course, a component of the so-called acute aortic syndrome, an entity that we have known by that name since 1998 out of that publication. These are three conditions or pathologies that share a common clinical presentation and the need for urgent treatment. IMH accounts for some 10% of cases of acute aortic syndrome, and that does not appear to be changing at the present time, according with the most recent publications. Unlike aortic dissection, IMH predominates distally, with type B accounting for about 60% of cases, which is sort of the flip side that we see with aortic dissection, as you all know. They are widely considered or accepted to be part of a continuum or continuing spectrum of disease, perhaps sharing many things in common, some of which we don't yet fully understand. Type A, like aortic dissection, can certainly threaten life and sometimes immediately so, requiring urgent treatment in the form of graft replacement of the ascending aorta. Overall, the natural history of IMH is one that includes all of those possible pathways: regression in resolution, progression to classic dissection, aortic diameter expansion, rupture, as you can see on that case. There is much variability in published reports about this, and it must be said that the behavior of intramural hematoma remains largely unpredictable. Things like that can happen in some cases, sometimes weeks or months later. This is 4 weeks later, forming a large PAU and a saccular aneurysm, as you can see on those pictures. 10 years ago, there was a European consensus that was published delineating with some clarity some of the manifestations and clinical presentations that would require urgent intervention as opposed to medical treatment alone. And I must say that we haven't really evolved much beyond that over the last 10 years. Type A, of course, can threaten life, as we said, and it is generally agreed that open heart surgery with graft replacement should be considered. But it is interesting to note that the outcomes with medical treatment alone for type A are really not well documented. And an observation that appears to be true is that many cardiac surgeons seem to be willing to act less aggressively in the face of type A IMH versus type A aortic dissection, waiting sometimes 1, 2, 3, 4 days or even longer before undertaking repair. For type B, it is generally agreed that in the face of one or more of these presentations, one should consider intervention as opposed to medical treatment alone. Aortic diameter, more than 50 millimeters, the thickness of the hematoma itself, more than 11, persistent severe pain despite BP lowering, and best medical treatment, image worsening, as I've already showed a couple of examples of that, or pseudoaneurysm formation, or of course periaortic or pleural effusion. Obviously, rupture would require urgent or emergent treatment, and IMH associated with PAU within the hematoma segment. In 2019, Panetone and his colleagues published a very good, interesting report out of an important experience with the observation that IMH hematoma thickness is really a rather important parameter to look at. And they found in their experience that a diameter of the hematoma beyond 8 millimeters foretells a poor outcome with medical treatment alone and should be in and of itself an indication for intervention. They present some compelling evidence, but I must say that I have not seen many worldwide experts embracing such criterion. From the point of view of the technique or the technical approaches, the procedure, TEVAR that is, tends to be technically straightforward because there is only one lumen to deal with, unlike dissections. The majority of experts favor endograft coverage of the full descending thoracic aorta, or at least the full extent of the IMH. One should land proximally in healthy aorta, same as dissections, often in zone 2. Minimal or no oversizing. And a note of caution, at the time of graft sizing, one must use luminal, inner-to-inner measurements for graft sizing. So I can tell you that this much we seem to know. It is relatively uncommon, essentially identical presentation with acute type B dissection. The complication potential, though, appears to be greater than with dissections. Yeah. Medical treatment is best for uncomplicated and/or asymptomatic IMH, and TEVAR is clearly now accepted as the intervention of choice when an intervention is deemed to be indicated or necessary. But we're also facing continuing uncertainties that are still lingering and don't go away. The precise pathogenesis remains unclear. Indications for intervention are undefined, more or less, in the absence of complications. And the extent of aortic coverage continues to be an issue because, of course, there is the ever-present fear of paraplegia, but one must perhaps resist that and cover more rather than less when the question comes up. Ultimately, we face a persistent absence of large prospective or even retrospective cohort data generating robust evidence on IMH-specific outcomes. Until that is available, I am afraid that we will continue to have those uncertainties as enumerated. Thank you.
Frank, yeah, Jim.
Frank, before you leave, Frank. Okay. we have a few seconds here. You know, in the last film you showed, you know, it had a very eccentric central lumen, and then this IMH you're calling. How do you tell IMH from a mural thrombus? Because I get some of these aortas that come through and they're kind of tortuous and everything else. You say, is that mural thrombus or is that IMH? How do you tell the
So you're thinking of a mural thrombus of what kind?
Just basically, as you have a curvature, some of my patients will just have mural thrombus along the aorta going down.
I mean, IMH is a mural thrombus. It's one and the same, right?
It's an intramural hematoma. How do you tell the difference between an aneurysm with thrombus in it and intramural hematoma within the wall of an aorta?
It can be difficult, but they often look different in terms of the bulging and so on. But there are times, it's true, where it's difficult to make up your mind as to what they are.
I think we all use pain as an indicator of this must be an acute event, but beyond pain,
well,
sometimes that can be difficult to
You have to put that together with symptoms and with diameter, of course, and perhaps even go ahead and, if appropriate, treat it anyhow.
Sounds like an IA program here, or problem. Artificial intelligence will figure it out.